really emphasizing the important problem of misdiagnosis. I don't know what the problem is like, the scale of the problem in Mexico, but in the United States, it is a big problem for many reasons. Access of patients to doctors, including neurologists, a low threshold for getting an MRI scan of the brain, the tendency for radiologists to interpret any white spot as possibly being demyelination, the failure of physicians to look at their own films, and then the failure of physicians to integrate the clinical findings with, that is both the history and the examination with the MRI findings, just as you've heard. So I'll give you an example of this. This is a gentleman that I saw last year in my clinic, 34-year-old man who was referred for atypical MS that wasn't responding to treatment. And he reported a 2-year history of a variety of symptoms, including imbalance, vertigo, cognitive impairment, right-sided tinnitus, and loss of hearing and blurred vision. His symptoms, he told me initially, accumulated gradually and never got better, although when I asked him about some of the specific focal symptoms, like, for example, the right tinnitus, he told me that that actually came on fairly suddenly, like from one day to the next. He was treated after his diagnosis of MS with dimethyl fumarate and then with fingolimod with no benefit. His exams showed that he was cognitively impaired. His spouse had to help with the history. He had nystagmus, hearing loss, and was very ataxic. And this is his MRI scan. And you can see that there are many lesions in the corpus callosum, a place that multiple sclerosis likes to live, also in the brain stem, another favorite place of MS. Other tests, including his spinal cord MRI, a cerebral angiogram, a spinal fluid examination, visual evoked potentials, and a lot of laboratory studies were normal. And ultimately, he had an audiogram that showed low-frequency hearing loss and a fluorescein angiogram that showed branch retinal artery occlusions. And we were able to, with help from my ENT and other colleagues, diagnose him with something called Susac syndrome, which is a rare and not well understood disorder that is associated essentially with very small vessel infarcts in the cochlea, the retina, and in various areas of the brain. A clue to this diagnosis is the appearance of the MRI scan. In this case, on the left, all of these lesions are very circumscribed and within the corpus callosum itself. And in contrast, multiple sclerosis typically shows these radial extensions from the septocallosal surface. Those are the so-called Dawson's fingers. So some people call the Susac's lesions snowballs. It depends on where you live, how familiar you are with a snowball, I suppose. In Arizona, there are many people that are not. But at any rate, the radiologic appearance alone was enough to raise doubt about the diagnosis. But so was the clinical history. In retrospect, I think if someone taking the history from the beginning and focusing on how the deficits accumulated, they would have raised several red flags. First of all, symptoms in multiple sclerosis rarely occur suddenly. I suppose double vision is almost always a sudden phenomenon. If your eyes are not yoked together, you see double instantly. But most other things occur gradually. Most MS attacks have symptoms that evolve over days to weeks, and then they plateau, and then they typically improve. Now, they may not improve 100%, but they get better, even without treatment, especially early in the disease. So to have a patient who has sudden onset or very acute onset symptoms and no recovery and a continued stepwise progression is already presents you a series of so-called red flags that a diagnosis of MS may not be appropriate. Why worry about this? Well, MS remains a clinical diagnosis. I told you earlier how excited I was about all of the things that were happening with neuromyelitis optica spectrum disorder. And that's largely because we understand that disease very well. Not well enough to cure it yet, but well enough to know its target antigen, the antibody, its function, its pathobiology, and that arms us very well with respect to treatment. MS, we still do not really know what this disease is, and its diagnosis really is very primitive. If you think of it, it's purely based on a clinical presentation of patients, whether they conform to a pattern consistent with inflammatory demyelination, compatible imaging, and exclusion of other competing diagnoses. There's really no biomarker as of yet that we use to either diagnose multiple sclerosis outside of standard imaging and spinal fluid tests, or the course of the disease. The course of the disease is purely still in 2018 defined as whether or not the patient has continued to have relapses and remissions or whether they have a progressive disorder. And that's important, but you can see it's very limited as far as understanding the biology. So in diagnosis, we're still faced with diagnosing patients based on dissemination in time and space, the fact that there are many disorders that can mimic multiple sclerosis and in fact fulfill diagnostic criteria for MS, and we don't have a biomarker that's diagnostic for the disease. We also know that we have a lot of available treatments, and in the United States for over a decade, the mantra has been diagnose early as possible to get people on treatment so that you can preserve their function. And there's some truth to that. I think some of that is true. But rushing to diagnosis, of course, can also cause harm. Retraction of a diagnosis of MS is very difficult. A colleague of mine from Rochester and I were speaking recently about two patients, one of each. We had each seen a patient, and what they had in common was they'd had more than a decade of diagnosis and treatment of MS, and they had also invested themselves very heavily in that diagnosis. Community involvement, Multiple Sclerosis Society, raising money, doing MS walks, Facebook, all those things. And neither of them had MS. And so you can imagine how difficult it was to retract that diagnosis after it had become so much of them as an individual. And then, of course, exposure to drugs that aren't appropriate for their disease is not only harmful for them, but very costly for all of us if we're paying the bill ultimately. This is currently a topic of a lot of interest in the field of MS. A colleague at the University of Vermont, Andy Solomon, has led some studies of this that we participated in, looking at what are the reasons for MS misdiagnosis. And the top 3 reasons basically come down to these things. Atypical symptoms, so that a careful history is not compatible with multiple sclerosis, or at least raises concern. Number 2 is that there aren't any objective lesions that are associated with the patient's complaints. So patients may frequently complain of paresthesias or vertigo, transient temporary symptoms, normal neurologic exam, but also on imaging, no lesions, no abnormalities that explain their primary complaint. And then, as I already mentioned, MRI misinterpretation or overinterpretation. And this is very, very costly in our healthcare system. So here are examples of what multiple sclerosis typically does look like. Periventricular lesions, as shown here. Lesions are usually ovoid. They cluster around the ventricles. Even when they don't, they're usually larger like this. You can see that around the posterior aspects of the lateral ventricles, it's kind of hazy. And there's a famous neurologist named Don Patey who developed the Patey criteria, radiologic criteria for MS when MRI was new, and he called that dirty white matter. And then you can see here how these lesions arise from the septocallosal surface and are oriented perpendicular to it. When you see that, it's not diagnostic of MS, but it's certainly a strong point in favor of it. Gadolinium-enhancing lesions are characteristic, and especially in the context of T1 black holes. So these are 2 slices, axial T1 MRI scans. And on this one, you see this lesion that's enhancing. On this one, you see an enhancing lesion, but then you see scattered around it little punched out black holes. That pattern is very suspicious in the right clinical context, especially a person under age 50 of MS. Excuse me. Juxtacortical lesions, so lesions in the white matter but adjacent to or just touching or even involving the cortex, is another point in favor of multiple sclerosis. And here you can see a lesion, sort of a U-shaped lesion right underneath the cortex touching it. That is a point in favor of MS. Here's what I referred to earlier, confusion between, or misinterpretation, I should say, of white matter lesions as being demyelinating, such as you see here, versus vascular or nonspecific, as you see here. And Dr. Halker had some examples of this too when she showed the kind of nonspecific lesions that she would see in her migraine patients. But these very small subcortical or deep white matter lesions scattered throughout the brain, nonspecific. Could some of those be demyelinating? Sure they could. The MRI doesn't tell us what the pathology is, it just shows us the shadow. But if that's all you see, you need more evidence to support the diagnosis of MS. So here I'll just show you some examples of remarkable patients that have been initially diagnosed with MS, but ultimately were diagnosed with other things, sometimes by my colleagues, sometimes at other institutions. It's just a nice visual collection. So this is an example of Behçet's disease, an autoimmune mucocutaneous disease that can affect the nervous system, and when it does, it usually affects the brain stem, as you see here. These are unusual lesions for MS because of their size, their very discrete borders, and where they occur in the meat of the pons, the middle part of the pons. This is a disorder called Klippers, and I think sometimes when people don't recognize this pattern, they get concerned that, well, I don't know what it is, maybe it's an unusual form of MS, and they treat it like that. But this is a strange disorder that, or strange syndrome, I should say, that after exclusion of a whole variety of things like vasculitis and lymphoma and Behçet's disease and other things that can cause the brainstem, is a lymphocytic infiltrate, typically of the pons, sometimes other areas in the brain, brainstem, or even the spinal cord, that responds very well to steroids. Neurosarcoidosis is a mimic of multiple sclerosis, and this is a patient diagnosed with MS on the basis of the white matter lesions you see on the left panel. But what was also not appreciated at the beginning was that this patient has, as you see in the middle and the right panel, evidence of leptomeningeal enhancement, which is not subtle, it's really fairly obvious, and not what we would see in multiple sclerosis. And this patient ultimately had biopsy-proven sarcoid. This patient had CADASIL, so autosomal dominant leukoencephalopathy, vascular basis, genetic disease. A clue in the MRI scan is involvement of the temporal tips. This would be a very unusual pattern of MS to have such confluent lesions at the temporal tips. And then finally, in patients with progressive disease, there's an additional differential diagnosis I don't have time to go into today, but this patient was diagnosed with multiple sclerosis and treated for years with chemotherapy, and in fact had a biopsy-proven leukodystrophy, so was exposed unnecessarily to a number of toxic drugs. I would recommend this paper. It's a decade old, but it's really sort of a classic in the field of multiple sclerosis, not as appreciated as I think it should be. This is a consensus paper. It was led by David Miller, who's an MRI and MS expert in the UK. This is a collection of legends in the field who led this consensus study that looked at diagnosis of MS, and it's a little bit outdated when it comes to the diagnostic criteria, but where it's really valuable for people learning about multiple sclerosis is the red flags. Remember that in any diagnostic criteria that have been developed for MS, the final statement is always no better explanation, and that's because of the lack of biomarkers. So that means that you've got to make sure the patient is presenting in a way that's consistent with an MS pattern, and there aren't unusual or atypical things that make you think it could be something else. So this paper, and there's some methodology here, looked at a variety of clinical, MRI, and laboratory findings, and how much they influence these clinicians in thinking about alternative diagnoses. And I just put one of the tables up here. This is, I think, probably only about 20% of what's in the document, but it gives some very nice examples to learn from, so I highly recommend it. I'm going to stop there. That's all I'm going to say, except for, as a general rule, look at your own films. Don't trust the radiologist, no matter how nice they are. That wasn't a very nice thing to say, was it? Okay.